Okay. Welcome everybody to Elevated Medicine. This is sponsored by Carolina Holistic Medicine, and I am very excited that on this first November podcast of 2025, we have Dr. Christian Ciora, is spelled Ciora, but you say it with the ch sound. He's from Romania, and he recently gave a very, very dynamic masterclass for Dr. Salibi's Priority Health Academy. And I'm just excited to share him with all of you because uh, just listening to him, you will feel truth like fireworks going off inside. And he is not like any of the other psychiatrists that you have probably met. Good morning, Dr. Ciora.
Good morning.
um,
Hi, Stephanie, and everybody else. Yeah.
So explain to everybody what is different between the psychiatry that we are used to and the psychodynamic, psychoanalytic work that you do, which I love that you called these toys that you use.
Yeah. Um, I kind of went into into psychiatry through medical school, so I could have become a psychologist if I would have figured out what I want to do sooner. But when I went into psychiatry, I went with the idea of doing more psychotherapy than med management. That was a far more fascinating um, aspect of mental health than to me than any other thing. So I was lucky enough to find a residency program that did a very good training. There were a lot of psychodynamic psychotherapists. Pretty much anybody who was teaching us was fascinated by psychodynamic psychotherapy. So that was a very good beginning. And then I continued with psychoanalytic training. From what I hear from elderly, more advanced people, is that this used to be a far more common
Mm.
thing in the past, that psychiatry used to be much better trained in psychotherapy than what residency programs offer now. And it's interesting to me that I'm seen as unique by a whole lot of people because I I spent a lot of time in psychoanalytic training where all these other people um, were there to do psychotherapy. So I still know psychiatrists who do psychotherapy. But indeed, in order to do psychotherapy, you have to do it on your own. You can't be, this may be, uh, you, there may be some small instances in which you can probably do psychotherapy as part of an institution, like if you're teaching it. But generally, if you want to do psychotherapy as an individual psychiatrist, you have to kind of go out of uh, you can't find a job that would hire you to do psychotherapy. You have to have private practice, or maybe a small group that would say, yes, if you want to do psychotherapy, fine. But it usually is seen as you taking a financial hit if because the medication, the E&M codes are better reimbursed generally than psychotherapy codes. So the industry disincentivizes practice of psychotherapy by psychiatrists.
Hmm.
So am I moving in the direction of answering the question? I forgot
Oh, yes.
because um, you were asking so I don't think I'm that unique, but indeed there are things that probably made me more unique because when the pandemic hit, it was pretty bad from where I was looking, and I was very disappointed with how our health leaders were treating the whole pandemic. I was far more afraid of the potential policies and treatments that would be proposed than of any virus. And I think what came only confirmed my fears. So in 22, when FLCCC had the first conference, I couldn't run faster in that direction. So that already made me more unique because there were two other psychiatrists, maybe I forgot, uh, at the meeting. And as far as hearing from other psychiatrists, like people who who are much better known, like I like riding under the radar, uh, flying under the radar, right? So it's not for me to just jump anywhere and make noise. That's not a thing I can do. But I saw that there were one or two. I know Aaron Kheriaty wrote some books, said some important things. I was very happy to hear that at least one psychiatrist steps up and says a few things. And Mark McDonald, I don't know. I know that there was another psychiatrist who had some strong opinions about his dissatisfaction with how things are going in healthcare in general, but also psychiatry. It was pretty in pretty bad shape. So I guess this is primarily how I'm here and maybe how I'm seen as more unique because I like psychotherapy, and of all psychotherapies, then I think of this psychodynamic school of thought as being superior to other things. Um, yeah. um,
Well, I mean, yes, I think that definitely marks you because you came out early, just like you said, Aaron Carey already, I don't know how to say his last name, but yes, I remember him making statements early on. And, you talk about the pandemic, and there were a lot of medical doctors also, looking at the medicine that was being prescribed for COVID and what was actually available. And, simply the fact that people needed more sunlight, um, and their defenses were really weak. And we saw a kind of mass delusion take over as people were propagandized and presented a different reality and than the one we were seeing. But I've heard you say that the delusions are a form of organizing overwhelming information, and that in a lot of cases trying to collapse that delusion or make people see the truth can be more dangerous than or more costly than allowing them to have your delusion. How do you how do you see the approach of um, many physicians who are trying to collapse that delusion, for people's own good?
uh, we can go in the direction of what I was talking about last time about the terms of blind spots and dumb spots. That dumb spots are when you just lack information, and just filling in that information fixes the problem. So that's clearly not the case here, is that there is a great reluctance for people to look at things that are inconvenient, right? So this is far more of a blind spot, and this is going in the direction of a delusion. Matthias Desmond, I read his book. Reading is in quotes. It was listening to his book on Audible, which is a different experience for me. I I'm not that great at paying attention. Uh, but anyway, I got it. I disagreed with some of his assessments of what is to be like capitalist or what. But his general idea is that you stress somebody enough, they are going to feel that their life is in danger, and especially in isolation, they would be willing to cling to anything, right? So they cling to anything that's a semblance of a structure, right? You take people, you feed them all kind of things to scare them to death, and then you come and say, "Hey, I'm the savior." Of course, if you're just a little bit persuasive, and you may not even need to be the persuasive in the context of, oh, on one hand, I may die, and on the other hand, there is a chance somebody's going to save me, you're going to take the ride. So this is, I think, what happened, that uh, it became a vital thing for people to listen to the authorities. And when you have, like, I can listen to the authorities, on the other hand, I can return to that state of disorganized anxiety when I'm afraid that I'm going to die next minute. What are you going to do? And the proposition now is that, oh, look at something else. Well, you have to relieve some of that anxiety, some dread, the dread of having uh, no structure. So once you get attached to that idea that, oh, this is the saving device, these are the people who are going to save us, it's very hard to detach, right? They became kind of gods, right? They gave you life. How are you going to detach from that? It's going to be close to impossible. Um, Robert Malone, after reading and popularizing Matthias Desmet's book, had probably the best therapeutic idea, is that you have to talk to people and you have to talk to them in a calm tone. So maybe your calm can become contagious and they can feed off of your calm. And in that case, once they maybe become calmer, maybe they can listen to actually the words rather than just your state of mind. So the idea of going and frantically uh, yelling truth at people won't work, because and I'm at fault for the same thing too. It's like I get intense about this stuff, and I'm probably losing audience. But yes, and by the way, it's amazing if you see Robert Malone talking. His tone of voice is so therapeutic. Like uh, you feel that he's on solid ground. So, by the way, talking about therapy, it's far less what you're saying, right, than how you're saying, and the fact that you're able to tolerate difficult states and you're still there, you're not running away. That does much more of the therapy than whatever you're communicating, the intellectual part communicating through words.
Yeah, like your presence. Does-
Yeah. So before you deliver the truth, you kind of have to deliver the safety. Like, that's not the only way you're going to stay alive, by the way. And uh, but probably the idea to go to somebody's delusion and say, oh, that's crazy. No way.
Mhm.
Uh, you're not going to reach that way.
Okay. So looking at what causes them to cling to the delusion and then countering that, and in this case fear was a big part of that. That
Yeah. And the delusion, it depends, but it generally provides at least some sense of mental structure, some organizing principle. It simplifies things, right? So it's a structure, it has its utility. And to just go and tell them, it's wrong, it's like, come on, it kept me alive.
Mhm.
Even if it's just an illusion, it doesn't matter, they are alive.
Hmm. All right. Okay, so that makes a lot of sense. One of the things that you said in our master class near the end that has it really got my attention and it has stuck with me very firmly. Speaking of delusions, you mentioned, like, for an example, let me get your quote exactly right. Calling a certain set of symptoms major depressive order is a delusion. But without context, that sounds, outrageous. Would you provide a little bit of context for that statement and expound on what you meant by that?
Yes, so this was in a Q&A after the talk, and the doctor said something about uh, some doctor who asked me if I know of a doctor who's studying neurobiology of delusions. And this is where I was saying that, if they want to find the neurobiology of any kind of mental uh, activity, it's fine, great, but I'm not there. But also, I do have a concern that people are far more inclined to look at the neurobiology of stuff. Uh, and look, they are going to try to treat it, but they don't necessarily take into account that these symptoms are not just misfirings by the brain that you can or should get rid of without further consideration. If it's a mental structure, if it, by the way, this is part of the psychodynamic school of thought, you don't really have seizure activity, like nonsensical things. Usually those are filled with meaning. So you can't get rid of one of these things without major collateral damage. So I don't think if you find something, you get rid of a delusion so easily because you have to find a better structure to replace that delusion. It serves a function. So when I called attention to the fact that, we all have beliefs that are convenient, right? And it's not really a delusion, it's a belief because people can reason around it. If I bring you my objection to the particular definition of major depression that is in use now, you probably would say, yeah, it makes sense. It's like I don't have to hang on to that definition as I used to, right? So my thing was that this was the way they defined major depression. That was an example because most of the things were decided on similar terms. Let's find a period of time. Let's find the level of intensity. Let's find the number of symptoms and call it something. So it's an arbitrary concept about where it starts or when do you call it a thing versus something else. It was very arbitrary how it was decided, but then people treat it as, oh, let's see if it's a biological illness. Well, you don't know. How can you start deciding it's going to be more arbitrary things being studied? So it functions in a way as a delusion, as a mass delusion, like all the healthcare devotes so much time and energy as if it's a real thing, as if these people are no different, right? Because I was mentioning that you have one overeating and one undereating, and one losing weight, another one gaining weight, another one not sleeping enough, another one oversleeping, and it's all in the same category. And then you're going to say that, oh, we're studying this as if it's one thing. Well, what if they are very different? I've never seen two people eligible for major depression, severe without psychosis that would be similar. They had very different, they are in significant ways very different. Same diagnosis, very different people. So the delusion, I mean, it was a hyperbole, I guess, or something. It's not correct to call it a delusion in that way, but the idea is that it's a concept that serves a function, right? It serves a function. We at least have the feeling that we know what we're talking about. If you go and talk about the details, then you find out that we may have different ideas about what we're talking about. But oh, we have a patient with major depressive disorder. Oh, yeah, we know. No, we don't. We have no idea. And
So
by
it's
the
like,
way, this thing, it gives the impression of knowledge, and they say, oh, so what medication are you going to give for that?
mhm,
Where is this conviction coming from? It necessarily it comes from the studies because then they studied for pharma.
mhm. So it's a simplified, convenient way of communicating something, but then to treat an issue with the mind, to treat it with a pill, uh, is treating the physical body and not the actual cause of the symptoms.
Yeah, it depends how it's used, yes, because if it's used as okay, this is all that we can know, it's not a good idea.
Mhm. Well,
It gives the impression of knowledge rather than being an actual knowledge, similar to delusion. And yeah, I was thinking about what you're talking about with removing delusions, that you have to have a good timing when you want to tell a child that there is no Santa Claus, right?
Mhm.
They Yes, and also the other thing when in the Matrix, it was very nice depiction of when Neo found out that he was living in a false world. It's They were saying we don't do this after a certain age because the mind can't adapt. It's too attached to whatever it thought to be true. So it can break somebody's mind.
Yeah. That example of telling a child that Santa Claus isn't real, that that really does illustrate it well. You have to take care before you do that because their hearts will break, or they lose something precious to them in the process. That's interesting. Okay, so I mean, one of the biggest problems, a practical problem that the practitioners who are trying to guide people to real healing, um, are these medicines, these medications that they've been put on. And since we're talking about depression, just sticking with that, what advice would you give them if they know someone needs to come off an antidepressant in order to really get the healing that they're after? Are there some people you would say don't mess with it, or and if you do think they should be weaned off, how can medical providers practically do that, and should they always refer to someone like you?
Um, Generally, whenever we went through medical school, had these multiple answer questions that never and always were the wrong answer. So there are people who may come off the medications with relative ease, and there are people with whom it may be better to just keep them on whatever they are, regardless of the risk. I have somebody in their 80s on medication that I think is a time bomb, like you can die. But I said, so what? Am I gonna become despondently depressed now? For like, I'm anyway on extra time. I don't want to mess with any of my meds. So yeah, it could possibly kill her. But also, she has maybe little to live. Let her live with some decent quality of life, because trying to do that kind of thing is usually with the view of some future greater quality of life. So it depends where you stand, and each one is very individual. And I'm looking at so many variables. I don't think you want to spend the time on that, but I look on so many variables that are really concrete stuff. But then also it becomes into what they think and what they don't even know, because it
Okay.
wasn't discovered yet. So they may think one thing or another that about how fast or how soon or what they expect to happen as a result of that. It makes, for example, a great difference if somebody was put on a medication for a minor disturbance, or they were put on a medication after a suicide attempt, that they are still traumatized, right? If somebody had an illness, I had somebody who had suicide attempts, many psychiatric admissions, ECT treatment, a diagnosis bipolar disorder. When she came to me, I think she was in her 70s. Uh, I was trained, by the way, at that time they were still training us that you stabilize and then you try to reduce the medication and keep the patients on the minimum amount of medication that keeps them well. Now I think it's a different mantra. Is keep them on what got them better, which to me it's not. I can't agree with that. Uh, and you can wonder who gets any benefit from that idea. But with this patient, after she started to see me, she didn't need hospitalization. She didn't need ECT treatment. And whenever she had an episode of something, we just pumped up a little bit of clonopin during an episode and increased the number of sessions, the frequency of sessions for a while. And last year, she told me she had to move to a different state, so she didn't continue with me. But we were lowering the medication significantly. So she went from that history, hospitalization, ECT, suicide attempts, to doctor, I no longer need any medication. I'm doing well. It took a few years, um, but it was possible in that case. I have a few more that went from a lot of medications to and serious history to nothing. But it was done in an individualized way, and I never knew how smooth or not the next step of taper is gonna be. But generally, it's a good idea that I usually tell people that you need to have a little bit of resilience built in, that you can take a few bumps in a road without them compensating, right? So I want to have them a reserve of resilience before you jump in a taper, at least that much. And then to know what to expect and to be vigilant as compared to scared and jumpy, right? Things may happen and we're going to deal with them as they come. And we may adjust the schedule based on how well or not the previous step went. Um, and it depends. You have to adjust your mindset and your plan according to what develops over time. It depends. I have,
So it's really important to understand what the patient expects that weaning process to, how they expect it to go. So you want to prepare them so that they're hopeful for something rather than fearful.
yeah, well, yes. And I had somebody who went up to, I think, 150 of Zoloft with OCD symptoms. And went little by little down. And whenever we went down a little bit, there was a little bit of resurgence of symptoms, but he was able to work with those symptoms from like therapeutically. We did therapy. We managed to make those symptoms into something very tolerable to get out of any dysfunctional patterns. And then we went to the next step and another set of symptoms. So every new taper brought kind of new therapy material, and once we dealt with that, we could go to the next step.
Okay.
There are people who can barely taper off 25 milligrams, and they get scared. And you have to have who knows what. Some people get discouraged and they say, I'd rather stay with this. So it's very individualized.
It reminds me a lot of how Dr. Salibi treats Lyme disease because they he he gives them a little bit of medicine and then all of a sudden all the little bugs that have been in hiding in their body, they come out and cause chaos. So then he has to treat those that little bit that surfaced from a small amount of medicine, and then he gives a little bit of more of the tinctures, and after after the patient has stabilized, and then that causes another the Herxheimer reactions. It's almost like you're describing a, a mental parallel for those physical Herxheimer. That's so interesting. Okay, so then you teach them how to manage and uh, manage or organize or um, govern those. Uh,
In a way, teaching sounds like it's a one-way information, but it kind of goes both ways. And even I see a lot of misattribution. Like people say, "Oh, I got anxious after I tapered down the medication," and then you find out it could happen both ways, or many times it's attributed to the medication when it's really something else, or the other way. It's attributed to something else when it could be the medication. So it requires, by the way, you can't figure that out in a 15-minute visit. Many times it's the last 15 minutes of a 45 minutes where oh, by the way, I forgot to tell you, I had a big argument with whoever. So I said, oh, so all along we were thinking it's a side effect from the medication, but you had a huge argument around the same time. So this is very frequent that happens, that uh, they completely dismiss a particularly big aspect of mental life and focus on this one thing because that was the only thing that was on their radar for what could happen. Oh, I could get withdrawal. So, yeah, part of therapy. You have to be open, and that's another thing is that patients may they don't necessarily know they have their need to believe, right? And then we have the need to believe our own stuff, right? If we want to believe the medication is harmless, we go along and we think, oh, that couldn't be the medication.
Well, so some of these obstacles, the practitioners not wanting to, I mean, there's so much ground they have to cover in these appointments, and to add, psychodynamics to that appointment is overwhelming to them, um, because they're used to having to be objective and remove themselves. But
Yeah.
you mentioned something about, um, the difference between, well, you both observe evenly and give attention evenly, but you are also involved, your feelings and emotions are also involved in how you analyze the person in front of you. Would you explain a little bit more about that, about how you involve yourself in the process?
Yes, I think even Freud wrote some stuff that all the medical training is built against doing the kind of work that he started to do then, and then it got developed over more than a century. But yes, we're a part of the psychoanalytic training is to learn how to use your own feelings to as a diagnostic tool about how the patient affects you. So you pay attention to other layers, not just to the intellectual aspect of what's communicated, right? You want to know uh, how that whatever is going on says something about where the relationship is as feeling transaction, right? Does the patient trust you? Does the patient not trust you? Does he see you as part of a system with an agenda to sustain itself rather than to care for them? That's going to be another thing. Um, how connected they feel with you? How do they feel whether you get them or you don't get them? Uh, if they like you, it's probably more like they're going to like what you give them, right? Is that going to be a magic pill for them? And they may not know it. They may think, no, I'm a rational person. No, but another part of their mind may say different, and they may not be aware of that part. So
What
even
other
if,
part, what
Hmm?
other part of their mind are you talking about?
Well, they may not be conscious that they think that you're some form of guru or somebody with a special knowledge, and you send them on an important mission. Right? We wanted to become great, right? We wanted to remove all these toxins from your life, and they already feel like they got recruited in a very important life-giving war that they are willing to give their life. That may be so um, important psychologically. We have to fight this holy war, and I'm going to be part of this holy war and going to remove toxins. And that alone can lift a lot of depression because all of a sudden, the way they went from aimless frustrations to now they are fighting on a good side, good guy's side, and that gives them a meaning. And now they have a war fighting for. So these are the things that probably people don't necessarily think about. Sometimes it's not important to know as long as things go well. But these are the things that probably you would want to do in a therapy setting is if you feel something towards a patient, how can you use that diagnostically? And we spend the, the the standard training, like the lectures, are 5 years, but most people do not finish their training in 5 years because then you also have to get patients. You have to have a certain number of patients. They have to overlap with each other. And by the way, I did not graduate clinically with that. I took a so-called academic graduation because after 10 years plus of courses and everything. And I said, oh no, you didn't have enough immersion. That I had, at least on my count, I had more than enough hours. But they said, well, but you didn't have enough at the same time. You need a little bit more. And I said, no, thank you. I'm done with that. But um, yes, it takes a lot of experience to really feel like you know what you're doing with this. And even I think even people who got full training, they would have still a lot of blind spots. A lot of their knowledge may have been absorbed like a doctrine rather than like what I was saying, the toys to play with, right? I like to think of this as play, and I also feel like, you know, whatever I adopted, I made it mine. I feel a lot of people function on borrowed knowledge. They never made it there, so then it gets to be allegiance maybe to the institute to that extent rather than to the patient. So for me, I feel like I bring my toys and I'm using them to help patients get better, and we're playing or maybe fighting together against some enemy.
I like the toy that you use of making movie references. Like
Hmm.
just in preparing for this interview, you know, we were talking about some things, and you pulled out a clip from a movie that illustrated perfectly, like almost like a mirror of what I had explained to you. And uh, I don't know, that's a very using the art to show people what you see from them is um, it is fun. You make it fun to talk
Yeah,
about.
and I use actually jokes and movie scenes in sessions with patients, kind of to to give them the chance to see what I associate with, in a way, maybe modeling, like, look, this is the way you look. And also I'm telling them what I understood because maybe I'm off. So they can say, oh, but that doesn't fit because it's this and that different. It's a tool to find out where you stand and whether you got a good picture of what they're describing.
All right. Well, now talking about the manifestation of illness, that was the other topic that you touched on that I felt like was really key. You were talking about conflict, inner conflict that results in disease, but most of the time, if I understood you correctly, that it begins in the mind, and then uh, we create some sort of behavior because of what that inner conflict, and then that behavior that is it that that is this the process that the behavior then leads to a habit that uh, that is detrimental to the health, and then you start having physical manifestations, or is the process more complicated than that?
I'd go. I don't even know if I got it, but it's more complicated than that. It's going to be almost always the good answer when it comes to this. Yeah, it is complicated, and even this thing, like, you know, Freud was initially said, oh, you know, they discovered that there is an unconscious, right? That there is actively repressed content when they dealt with the hysterics, right? Because they found out that the mind is capable of producing the symptoms because under hypnosis you can undo stuff, or you can create symptoms in an altered state of mind, and you can remove symptoms in an altered state if they were created by the mind. So they discovered something very important, and they started, well, how are we gonna have a theory about that? So the mind is capable of repressing content, right? So that means you have a censorship apparatus, right? You have an agency that can remove things so they are not accessible to consciousness. Now, this is Victorian era, right? So we know what people weren't allowed, that they were very repressed sexually. So uh, it was not okay, for women, it wasn't okay to have sexual desires, maybe at all, but certainly not towards other people. Like you have to have only desires towards the legitimate partner, right? So it's a lot of repression. They had no other ways of dealing with that rather than saying, I don't know anything. I just have these symptoms, right? So it becomes so then of course it became like, you have the id, which you're not allowed to want to kill somebody who you should love, and you're not allowed to have sex with some people with whom you're not allowed to have sex. So it's better not even know about it. So people, that's why it became the most of the id. The id is the drives would be repressed, right? You prefer to not know anything. And then you have the other part that has to deal with the world, which is the ego. So that does the repressing and also does the negotiating with the outside world. And then they realized there is a critical agency, the superego, right? Superego has the rules, like you shouldn't do this. And there is another part, then that's the ego ideal, which says, well, if you want to be good, this is the kind of things you should be doing. So one is prescriptive, the other one is restrictive, and the ego tries to make peace. Like, oh, you want to have a cake, but then the reality is such, and and the rules like for dieting are such, right? So you have to make peace between the internal rules, between the restrictions of the reality, and so rules, desires, and external reality. So the ego has to figure out a way. So I think a lot of recent psychiatry and even psychology, they put so much of an emphasis about the conflict between the person and the external world. To me, that's not that much of a mental illness. It's you can have your whole mind in harmony about how you're going to deal with the external world, even if it's a hostile world. That's that's kind of developing a strategy. The problem that becomes mental illness is when there is the internal conflict, like those agencies inside your mind can figure out what they want to do. So one is pushing, the other one is pulling. So then it becomes the forces go in different directions. You end up with the resultant force of zero. So you feel paralyzed. So that is when you can't have your mind figure out a way to function well for yourself because it's in conflict, right? So you spend so much mental effort into this internal struggle that you have very little left for dealing with the external world.
And the harmony between how do you help people, how do you guide them to a harmonious place?
It depends. It depends what they do, and uh, that would be very hard to describe.
Because every situation is going to be different. Um,
Yeah.
well, what obstacles do you see standing in the way of other practitioners recognizing this or um, being able to utilize some of the toys that you're talking about?
Well, I assume to a great extent this is uh, practical. Like you need to have some experience, some growth and experience to be able to work with this. But there is a basic thing that in psychodynamic psychotherapy is probably the only therapy that's based on the assumption of the doctor doesn't know. Most of the therapies, most of the medical profession is really the doctor knows. In that case, we even have the jokes about the psychoanalyst, how he stays there and it looks like a joke, like, tell me more about it. Or the psychoanalyst meets somebody and somebody says hello, and the psychoanalyst says, what do you mean? So, yeah, it becomes like, you see, all of these things, like, I never know enough, right? Tell me more about it. Ultimately, it becomes that you reshape those forces, you redirect those forces so they become more in line with each other. You try to get the mind to not fight itself so much.
Okay.
But it depends who does what. I struggle to find an example but nothing comes to mind now.
Well, Well, is there anything else that you want to add? Because I know you have this very abstract understanding of things, and we're trying to funnel it all down into a small bit of time. But what is pressing on your mind, or what are your current interests? What do you want people to know?
Um, so I don't know if I emphasize this enough. So I like very much this position of lack of knowledge because it's it's very humble, and I think it fits with the human nature is that it's impossible for us to know all that there is to know. So I think that's a great attitude to have, to always look like I don't have the full picture. I don't have the full picture. What am I missing? What am I missing? All the time. Uh, I think that's pressing because you see how all the agencies are very much into sustaining themselves, and I I feel that I created the bubble at some cost to, I only take payment from the patient because then whenever you get other people involved, they are going to have an agenda. So for me, the greatest thing to happen would be to to make the doctor-patient relationship uh, back to a private one, a privileged one. I keep telling people, HIPAA, do you know what the one of the P's in HIPAA? It's portability. How is that possible to be compatible with confidentiality? It's impossible to have portability and confidentiality in the same thing. So
Yes.
there is, I think the relationship between doctor and patient w- should go back to being something more sacred, something that's, untouchable by who knows who. If the patient wants to get reimbursed by the insurance, the doctor should be no part of that to the extent possible. Now, most of the treatment that I provide is elective, right? I used to work in a hospital, so sometimes people do not have, and that's the more needy the patient is in the situation, the more chance for abuse is. So maybe that there is something to be said about who's going to monitor that things go well. But in my situation, most all that I do is elective. People self-select about who comes and who goes. What's the point of getting a third party to breathe down my neck, uh, or have us say, oh, why do you do that? Only the patient should be entitled to ask, why do you do that? If it doesn't look right or feel right, that it should be. So I would very much want to get anybody who doesn't belong out of the room when I have to deal with the patient. I can only serve one God, right? So during those minutes where there is a session, I can have only one God. I cannot have the insurer. I cannot have Fauci or whoever. No, I'm I have to be able to serve one mission at a time. So that talk about that's the most pressing thing in a way to reestablish some sacred connection rather than all this thing like you can have if you have an EMR, you have a billing agency, then you probably have CMS and who knows how many other people. All of them, if yeah.
Competing and influencing those
Yeah,
interactions.
pharmacy, disability insurance. I got a treatment so hijacked by the disability insurance. They never had enough. And the patient was a lawyer, so he was also very much into like looking at all the details about how you formulate one thing or another. So it's terrible. Like we even talked like we became the client of this third party. We were working for them to make to for them to say, okay, okay, you can have your yeah, you can have your treatment.
I love that word. Well, we'll maybe end there with the word sacred ringing out in everybody's mind that there is so much competing for um, for purpose in those interactions between doctor and patient, and the more sacred we can make it, the better for both. That's really, really good.
Yeah.
Um, all right. Thank you. That's the other thing. I wanted to say this to you too, because I know you were talking about some of your heroes that you've studied, and you mentioned Jean Martin or Jean Martin Charcot, and I think, all right, tell me if I got this right or not, but when you said how much you respected them because they've endured ridicule, um, they staked their reputation on unpopular truth. Uh,
Yeah.
I felt like that actually describes you as well.
I'm not that popular. I mean, these people became worldwide famous. Charcot was the best doctor of in in the world at his time, and Freud, who doesn't hear Freud's name? So sorry, I don't see myself as anything close to that,
So
uh,
you've done that for me. You
but
have.
I tend to lose friends over having too big mouth about saying stuff that maybe people are not ready to hear talking about. Yeah, shaking people out of a delusion. No, so
Well, I just thank you for what knowledge you have collected. I thank you for your humility in sharing it, and how you have, um, you know, no pretense of formality. I felt like I've entered that sacred space with you over our time that we spent, and I just want to give everybody a way to contact you. What's the website for where they could reach you if they.
yeah. So first, I feel like I didn't say almost anything. Sorry, I don't know what. I hope people got something out of it because I feel like I barely touched on a number of things. But my website is my first and middle initial, so it's CD. My last name CIORAMD at .com. Yeah. So actually, a search on my name should lead to the website, and that would be a good place to contact for anyone who wants. Yeah.
Okay. Well, I hate to close our window because I could talk to you all day, obviously, but I guess we've filled up the time. So maybe we can talk again when you have time.
Well, thank you very much for having me. I hope, yeah, I know a lot of people are primary care, and I don't know how much they can use this, but getting familiar with a little bit of some literature on psychodynamics can probably get you a much a good feeling about a better feeling about what this is about. And one of the authors that I liked a lot, for especially for somebody who's like wants to begin looking into this, is Irvin Yalom. He wrote a number of books, some of them fiction, some of them based on his therapy hours with patients. He's an excellent writer. And even this In Treatment was the HBO series with Gabriel Byrne. I only watched the first three seasons, but it's not necessarily a model of how to do psychotherapy, as people may see, especially with one of the patients. But um, it is a place where you can find a little bit about how things work and give you uh, bits and pieces to think about what is it like to work with the mind rather than with substances and things to be taken by mouth. And um, just why would advice not work, right? Because we're talking about blind spots and dumb spots, and uh, you can give all the advice, it doesn't matter. So yeah.
I want to check that out myself.
Yeah, but thank you for having me. I hope this was useful.
If for no one else, it's useful to me.
All right, thank you. Thanks.
All right, we'll be in touch.
All right, sounds good.
Bye bye.
Bye bye. Thanks.